appropriate? And at what level do you confirm that? In fact, that is the more reason why we have problem with people just giving the antibiotics without requesting for culture. Because what will show you that your own was appropriate is a combination of the clinical response and equally, the results of the culture. Sometimes clinical response might not necessarily be as a result of only the antibiotic. You have many other interventions you're combining with the antibiotic therapy. And they may be the reasons why the patient is getting better, not necessarily the antibiotic. But what will explain further or confirm to you that you are appropriate is when you have the culture report and is telling you this is the organism and this is the antibiotic and that was what you have used as the case may be. The issue of viruses, we have even visited several departments, even though most people don't pay attention to even the bacteria that are common, let alone viruses. But we have, I think, kits for the detection of herpes simplex 1 and 2, cytomegalovirus, even the torches. And I'm sure you know that it is available. But at the point we are almost saying, you get these things, people will say they want, when you bring, they will not request. We identified, recurrent miscarriages, preterm deliveries, and said these touches, probably some of these pregnant women might be having some of them, and there is need to defer subsequent pregnancies, but we have problem people requesting. And so that culture is what we need to change. In our own case, if there is need for something and we can get it, then as much as possible we'll get it. The only problem is when we get and people or clinicians don't respond by requesting for that. And don't also forget that aside the viruses, we also have some atypical organisms that are not culturable in the context of what we are doing. So, for instance, if you have some of them, you cannot really see them in the culture. So the yields are with respect to negative blood culture. Now the standard is to take at least 2 sets of this blood culture per patient, and that will improve the yield to, let's say, 70 something percent for the chance to get the organism in question. But if you just take one, which is the usual culture, even in pediatrics, because of the cost, and we know the risk, then you have barely 50 something percent chance of recovering the pathogen. Some other factors that will contribute to the chance of recovering or getting back the organism is the patient being on prior antibiotics that may likely affect the growth of this organism, and the period or the timing, because some of the organisms, the variation in when they are, present in the bloodstream also determines whether you will get them or not. So there are instances that you have to take serially over a period, but these are all issues that we can say are things to do with the cost, basically. So the issue of policy, I believe we had several discussions. We had some few guidelines, but we are trying to harmonize and come up with a hospital-wide policy, which we hope to share and also carry along the other departments to review and bring up everything, so that it's something that we can all operationalize together. That is, I think, the next phase of what we hope to do. Initially, we're a bit skeptical, trying to say we need to wait until we know our real experience. So the initial battle was for us to have a reasonable data to rely on, that this is the pattern we have. If you are talking about urinary tract infection, these are the common organisms for surgical site infections, these are the common ones for this. But when we are still battling with almost 80-90% not requesting for the culture, so how will you know the organism you are dealing with in your environment? It is difficult. And that's why I keep saying that if you just prescribe amoxicillin and you prescribe ceftriaxone, if everybody were to be like you, how would they have known that this organism can respond to this antibiotic? So we keep doing it blindly. But if we need to have our own local data, now we have summarized, just like I presented the one for 4 years, we can have like 5 years, and that is something we can rely on. Say yes, if we give you, we are sure we are giving you something that is purely based on our local context, our local experiences, and we hope we will continue with that, and we'll continue to relate with